So I'm Rachel Edwards. I'm one of the ACCS CT2s. I'm an emergency medicine trainee rather than anaesthetics, so please don't judge me. And I'm going to have a chat today about this document, Safe Sedation of Adults in the ED. It's a joint document between the Royal College of Anaesthetists and the Royal College of Emergency Medicine, released in 2012. And basically, the goal of it was to set standards for good kind of clinical practice for sedating adults in the ED. You might wonder why I am presenting this to anaesthetists. I think it's probably because increasingly, I've found anyway, particularly here at Heartlands, we're having to call anaesthetics to come down to ED to help us sedate people. I think partly that might be because in ED we're often, well, same as in anaesthetics, quite pushed for time and resources, and we've often not got as many regs or consultants available to do the sedation independently as ED doctors. So we're often asking for your help. So I wanted to go through the definitions of sedation because that's quite a big part of the document, and you need to understand it in order to know the different requirements for each level. The document states that sedation, rather than being kind of set levels, it's more of a spectrum, and when you're sedating someone, they can kind of move along that spectrum, and it can be quite difficult to assess where they are along that spectrum as well. But it basically ranges from them being normal, alert and conscious at one end to complete unresponsiveness at the other end. And there is an ASA definition which categorizes it into levels 1 to 4. So level 1, that's minimal sedation, also known as anxiolysis. So examples of this would be, for example, giving somebody Entonox if you're going to reduce a dislocated finger, or as an adjunct in, if you're doing something like relocating a distal radius fracture, you might use it along with like regional anaesthesia. And in this level of sedation, people will respond normally to verbal commands. Their cognition and coordination might be slightly impaired, but their airway, breathing and circulation is all their own, they're managing that themselves. Level 2 is moderate sedation, also known as conscious sedation. And it's basically a drug-induced state where there's depression of the consciousness, but you can still communicate verbally with your patient, either alone or with just a little light tactile stimulation. You don't need to support their airway or their ventilation, and their cardiovascular function remains intact. So common examples in the ED would be, well, quite commonly I've seen opioids and benzodiazepines used for cardioversion. Quite a common thing to do in the emergency department. Level 3 is deep sedation. So this is where the patient can't be easily roused, but they will respond purposefully, either with repeated tactile stimulation or painful stimulation. There may be some impact on their ventilatory function, and they may need some assistance in maintaining their airway, but usually their cardiovascular function remains intact. And examples of this would be like using propofol for sedation for certain procedures like joint relocations. And then level 4 is general anaesthesia, which we all know. So this is where they're not rousable at all, not even to painful stimuli. Their airway, their breathing, and often their cardiovascular function will need support. And they'll need positive pressure ventilation due to neuromuscular depression. And actually, general anaesthesia is not going to be done very commonly in the emergency department at all, but I'll talk about that a little bit later on. And then there's this other kind of level of sedation which doesn't really slot in the levels 1 to 4, but they've defined it in this document. And that's dissociative sedation, which is becoming more common as ketamine is becoming more and more common and used more commonly in the emergency department and also pre-hospital. And it's basically a trance-like state where their airway, breathing and circulation is fine, but they've got profound analgesia and amnesia. And often you can't communicate with these patients, and it can be quite difficult to know where they are on the spectrum of sedation, and for that reason the document states that it should be treated as level 3 or 4 sedation. So the clinician performing it should have the knowledge and skills to recover a patient from the general anaesthetic. I won't read all through this, but this is basically a table that we have in the document going through the different levels of sedation and what the minimum requirements are for performing it. So, like with minimal sedation, it can be a doctor or a nurse. All they need is minimum ILS, and it can happen anywhere in the ED, or you need to stop it. And that's ranging all the way through to the deep sedation and analgesia, where you need a doctor to sedate, a doctor to do the procedure, and a nurse. You have to have IAC and level 2 sedation training, and it has to be resusc room facilities. So the document does actually state by resusc room facilities, it means you have to have a difficult airway trolley, you have to have a tilting table, there has to be suction. And yeah, it has to conform to all the AABGI kind of standards and guidelines for general anaesthetic. I really briefly wanted to mention this. There was literally only a paragraph in it in the document, but that's ED RSI. And by ED RSI, I don't mean anaesthetists coming to ED to do RSI. I mean ED doctors doing RSI independently, which is something I personally haven't seen here at Heartlands, but other emergency departments I saw it quite often. The document basically states that it's classified separately to general anaesthetic. You can't just have RCOA IAC sign off, it's not enough. But currently there's no kind of standard in the emergency medicine curriculum for sign off. So it states that you have to have IAC, but you also have to have local sign off, whatever that may be, but there's not really any standard for that yet. And I think also EDRSI, unfortunately, is something, well, I think it's unfortunate that ED doctors are doing this commonly. But maybe with support from our anaesthetic colleagues, we could be assisted in doing it a bit more frequently. So documentation. So the guideline states there has to be a procedural sedation checklist. I did try and find a copy of the one they have here in ED, but if you do look at it, it basically, you work your way through it and it has things at the top like airway assessment, assessment of aspiration risk, assessment of fasting status, so it kind of takes you through a bit of a kind of almost like a pre-op assessment. There are consent forms that have to be signed, and there are standardised documentation forms for how often observation should be done kind of during and post procedure. And patients have to be monitored until their consciousness and their vital signs are back to what they were before they were sedated. And it talks a lot in the document about the clinicians who look after the patient during the recovery phase. You have to be trained at the same level as a recovery nurse. Now I know here in Heartlands, the research, they have a lot of ADPs and they have the same level of training as recovery nurses, so it's often them who will look after them post-procedure. And they have to be discharged into the care of a responsible third party with verbal and written information. Fasting. So fasting isn't required for level 1 or 2 sedation, but for level 3 or 4, the rules apply the same as they do for elective general anaesthetic. There is a bit of a problem when it comes to people who need procedures as a bit of an emergency when they're not adequately fasted. So it might be things like trauma, if someone's got like a dislocated ankle with a ischemic foot. You need to consider things like how urgently do you need to do the procedure, can it be delayed at all? You might have to think about the depth and duration of your sedation, and also think about other patient factors as well, like the aspiration risk and the airway assessment. So, like I said, it might be necessary to delay it. You might need to adopt an alternative technique like using regional anaesthesia, so things like hematoma blocks or Beers blocks, and you might need to modify your sedation technique as well. This is the Royal College of Emergency Medicine guidelines on the different medications to use for sedation. So I think it's quite a useful thing to have the doses, how often you can repeat them, the onset time and the peak effect. So it's quite good guidelines to help you with that. I think that it depends on what ED you're in and what ED doctor you're working in as to what drugs they use. Here they seem to love midazolam. In other EDs I've worked with, they seem to love ketofol. So it really varies depending on kind of the clinician's preference. So these are my references. There are a few good learning tools. The RCEM Learning website has a good e-learning module that takes you through procedural sedation in the ED. And also there's a really good blog on life in the fast lane on pediatric procedural sedation, which is really good. I'd recommend reading them. Any questions?
I think it's interesting that you spoke about the ED clinician-led RSI, and I think, as you say, it's very area-specific. I've got a friend that works around Manchester. I know MRI routinely do all of their RSIs in the ED department. However, they then have the facilities to look after them themselves.
Yeah.
So if they've RSI'd somebody and ITU are busy, it doesn't suddenly become you need to come and get them now. They actually can then look after them, monitor them, which means a whole sort of extra bit of setup and tying people up.
Because I think when I was in F1, like 5 years ago now, the ED I worked in, the ED consultants were all military and they were all pre-hospital trained, so they would all independently RSI frequently. And also the department wasn't anywhere near as busy, so they could look after them when they were like ventilated. Whereas here at Heartlands, I think the experience of the ED doctors is different, but also we're so much more busier 5 years down the line than we were 5 years ago, that they don't have the facilities to be able to have one-to-one nursing care. So,
it's a shame you don't get the opportunities to as well. You go through the IC for a year to be anaesthetics.
yeah.
Potentially not used most of those.
Yeah, because the majority of the regis I've spoken to haven't actually done an intubation since their CT2.